move the presentation of Dr. Siddharth Dikshit little ahead. Just to introduce, Dr. Siddharth is an alumni of CMC Vellore. He has done his DNB and fellowship from LV Prasad Eye Institute and is currently a faculty at LV Prasad Eye Institute. I had the opportunity to work and study together with Dr. Siddharth at LV Prasad during my fellowship. I would say that he is a teacher par excellence, and I would count him in the league of the greats like Dr. Ravi Thomas, Dr. GC, Dr. Mandal. He's excellent teacher. Even today, I use some of the tips that he had given me during my training days. I'm sure his talk will be very useful for everyone. And he has two talks. The first one is case-based discussion on HBF, and second one is on interesting cases. So he has double talk. I think he will be taking one after another. So please note that he will have double time, like time for two talks. So Dr. Siddharth, I think you can start your talk.
Thank you. I hope I'm audible and my slides are visible.
Yes, you may start.
Yeah. I have never felt such pressure even during my DNB exams like you have created, Ravi, with the superlative words, which I humbly can say cannot be true. The teachers that I've had, they have been so great. The only similarity that I see between myself and Ravi Thomas is the shining head, if I can take off the cap. But given the fact that I have to go to the clinics, I'll defer that. Thank you so much for having me here. And hello, Kolkata. My alma mater is at Calcutta, and it's a pleasure to be back, even if it is virtually. And I hope and wish that I come back to Calcutta as soon as possible. So the first talk is about visual fields and how you can utilize it best to diagnose glaucoma. I will be talking about it in a manner so that you don't, one, miss a glaucoma, and second, don't misdiagnose a glaucoma. So what I have learned from Dr. GC and I'll be talking about today is correlation is the most important factor. The only reason why these printouts of visual fields and OCT do not have please correlate clinically statement written there is because they don't mention the diagnosis on the printout. So instead of thinking that if it's not written, not written to correlate clinically, you can ignore it. The fact is that it's entirely of our responsibility to call it glaucoma or not glaucoma when we are looking at the printout, and the company will not take any responsibility. All it gives to you is a set of images which are statistically calculated, colored, and shaded. So the first important thing is to correlate the location. Now, when we look at this printout, what we can see here is there are defects here in the superior hemifield. These fulfill the Anderson criteria and can be glaucoma. For example, candidate in the exam, they should say that I will correlate with the disc. Now, how do you correlate with the disc? Now, this is the visual field on the right-hand side and the optic disc on the left side, not visible clearly. So we will try to zoom in. And if we had to draw a diagram on this, we can easily draw. I'll just go backward and forward so that I can just focus on what I'm showing here. What you can clearly see here is an excavation along the neuroretinal rim and oval shaped cup. So we typically just mark the cup with a hash kind of a thing, and excavation as shown here with the dots. But it's not only important to zoom in and look at the disc, it's also very important to look at the nerve fiber layer defect. And we can clearly make out that there is a nerve fiber layer defect inferior temporally, and that is correlating with the excavation that was seen earlier. Now, this is what is called a perfect correlation. When you see an inferior defect, inferior excavation or nerve fiber layer defect on the disc, and you see a superior scotoma in the visual field. So this is what correlation by location is. And this, if you put these two together, you can be sure that this is glaucoma. Now, what else do we need to correlate? It's not only the location, we also need to correlate the extent. Is the amount of defect that we see on the visual field correlating with the damage that is seen on the disc? And the best example of how you can do it is by forcing oneself to not only look at the extent or not only look at the nature of the defect, but also kind of quantify and serialize which of the defects on the visual field are the most significant ones. So if we look at the right and the, so what we can see here clearly is the extent of damage on the disc and the extent of defect on the visual field matching quite well. And if we practice this regularly, we can comment on the extent of the damage and the correlation of that. So while we had the visual fields correlating perfectly well with the visual fields in the last two examples, there can be a situation where the visual fields fail to catch what is happening on the disc. What you see here, though it is a little unreliable disc, the pattern deviation plot does not show any defects. So this was quite repeatable, and even when we had a reliable field, there was no defect on the 24-2. This is the 24-2C pattern, which has 10 additional points. So if you see this C here, these are the additional 10 points that are there on the 24-2C program. And these are the points which were typically missed by the 24-2 traditional program. And these are supposed to catch glaucoma early. However, even this seems to be quite normal. So we expect to see a normal disc, but is the disc normal? No, when we look at the disc, we can clearly see a large size disc with the inferior rim being lesser than the superior rim, possibly an excavation here. There might be a concentric thinning superiorly. What is very evident is a nerve fiber layer defect inferotemporally. So before we call this pre-perimetric, we need to do a 10-2, which for this patient, we don't have the printout. But what will help here is again an OCT. So this is a situation where the visual field had actually missed the inferior nerve fiber layer defect. And though the disc showed a significant damage, the visual field was unable to pick it up. So just like when you get, or say the PM office gets information about a security threat from one agency, it will go to another agency to confirm and then probably confirm it with the foreign services before it can actually go on an all-out war. So before we decide on treating or not treating a patient, we should not look at only one parameter, either the visual field or the disc or the OCT. Just like the PMO would do, consult with each of them separately. So individual assessment of disc followed by individual assessment of visual field, followed by individual assessment of OCT. If two of them point towards the same thing, then it is probably glaucoma. If all of them do it, then there is no doubt. Even if all of them don't do it, but two of them do it, then you can be quite sure that this is glaucoma. If not, then we have to reassess and relook. Now, the correlation does not extend to only the disc and the nerve fiber layer defect. It goes beyond and must go beyond. Now, what we see here on the right side 24-2 CETA standard printout is in the inferior hemifield defect that is occupying the arcuate area and the nasal area involving the central points and the paracentral points. Looks quite typical of glaucoma. But is there a surprise in hold? The 10-2 also correlates quite well with the what we saw there on the 24-2. How does the disc look like? Now, this is the disc. Does it correlate with what we have seen there on the visual field? Now, the superior rim is lesser than the inferior rim. Is this a thinning? Is this an early nerve fiber layer defect? Let's zoom out. Yes, it is a nerve fiber layer defect, but glaucoma is not the cause of that. What we can see here is clearly hemorrhages because of a branch retinal vein occlusion, which can result in nerve fiber layer defects, also cause pallor of the rim, but the defect that we saw is not because of glaucoma. Now, there are certain hints which we can get in the visual field, which will tell you that this is not glaucoma. One thing that is typical of other defects is a very straight margin here. The defect has very straight margins, which is atypical of glaucoma. And in fact, you are likely to see a slope. So denser points centrally with less dense points in the periphery. And whereas this scotoma is very strictly localized. It is not an absolute scotoma, but if you see what is called the slopes of the scotoma, the areas adjoining the defect, they are all completely normal. Whereas the glaucoma, this would have gone from probably 27, 26, or increased from 27, 29, 31, and increased in various directions. That's a gradual slope, whereas this is a perfect cutout and the straight margins, which can be hints to pick up defects which one might think is not glaucoma. Right. Why are the slides playing again? Right. So this is another example of pre-perimetric glaucoma when the HVF 24-2 and 10-2 have not been able to pick the defect up. The same patient, but the nerve fiber, it shows pretty well on the OCT. So there is important aspect to remember that the 10-2 has a separation of only 2 degrees compared to 6 degrees on 24-2. So what seems like a defect, which may not even follow the Anderson's criteria, actually it does, but looks like a very minimal defect on 24-2, and you might think this is an early glaucoma. When you do a 10-2, you will find that it does not only occupy a large part of the center, but also is very close to fixation, which means it is close to threatening the vision. So this is a glaucoma where you really need to be aggressive on treatment, lower the intraocular pressures like you would do for an advanced glaucoma. And this is the disc, again, correlating with the inferior near notch and excavation there. Sorry for the photograph. So what we learn from here is that sometimes we may not have a significant defect on 24-2, but once you have the fixation central points involved or the paracentral points involved, so these 4 central points, along with any of these paracentral points involved, one must do a 10-2, and it may throw a surprise or a timely caution and warning that you need to control this a little more aggressively. So just to sum it up, correlate the location of the defect on the visual field with the damage on the disc. The inferior defect should correlate with the superior disc damage and vice versa. Correlate the extent, getting into the practice of looking at the severity of the rim damage, especially if you are looking at one eye, and both eyes put together if you have the photographs and you can draw a disc diagram. Do not forget to look at the retina beyond the disc and the nerve fiber layer defect. Sometimes non-glaucoma related pathologies can easily mimic a glaucoma related defect. There can be glaucomas which are pre-perimetric, and then you need to consult your brain and your examination and the OCT. And do not forget to do 10-2 whenever you see a central or paracentral point involvement on the 24-2 program. Thank you so much. And if there are any questions, I'll be happy to answer.
So is your presentation part complete, or like you have anything more?
Yeah, this one is done, Dr. Ravi.
I think you can go ahead with the next presentation. We're running short of time, so you can continue with the next one.
Okay, because there was no buzzer, I thought I was ahead of time. That can never happen.